This is the first lecture on the second system to be covered in A&P 2. This is all part of the material for lecture exam 1. So we're going to look at the cardiovascular system, and we're going to break it up into blood for this lecture, heart for the second lecture, and vessels for the third lecture. Regardless of what we're looking at a circulating transport system that uses a pump, it uses tubing, and there is a fluid, right? So the pump is your heart, the tubing is the conducting system, which is your blood vessels, and the fluid is your blood. The jobs of the cardiovascular system is transporting to and from cells, whether it's oxygen and carbon dioxide, nutrients, hormones, immune system components, or waste products. And these are the things that we've talked about over and over again. Beginning in A&P 1, when we talked about transport, we talked about what are we transporting? Oxygen and glucose and maybe estrogen. We're transporting these things, but we're also picking up waste. You also know from A&P 1 that blood is a connective tissue. And remember what we talked about with connective tissues. You should never see it, right? So this is a specialized fluid connective tissue. There are cells that are found in this fluid matrix. Blood functions include transporting dissolved substances, like we just talked about, oxygen, nutrients, hormones, waste, right? But we're also talking about maintaining homeostasis. So we're looking at pH and ions. We're trying to move calcium around, bring it into a cell, take it out of a cell, because we're looking at diffusion with interstitial fluids and blood. We're also trying to make sure that our pH stays in balance. So absorbing and neutralizing acids is also part of what we do with blood through the regulation of pH and ions. Stopping bleeding, restriction of fluid loss, clotting is a function. Defense, right? Part of your immune defense, white blood cells are transported by the blood to fight infection. And we're also stabilizing our body temperature. So if you're hot, you may be flushed because your blood vessels have moved closer to the surface of your skin. If you're cold, then like really, really cold, your appendages may become pale. Because blood is being shunted from your appendages to keep your core, which are your internal organs, and your brain from shutting down. That's the reason why a person can get frostbite, because your body is shunting that blood and slowing circulation in your appendages to keep your vital organs and your brain working. Whole blood can be broken down into two main categories, either plasma, which is fluid proteins in solution. It's very much like interstitial fluid, right? The fluid that's around your cells, plasma and interstitial fluid have some great similarities. But you also have the formed elements, and that's all the cells and the solids within the blood. So, plasma has water, proteins, other solutes, and it's the matrix for the formed elements. Your formed elements include red blood cells, white blood cells, or platelets. Red blood cells can also be called erythrocytes. I shorthand them to RBCs a lot. White blood cells, shorthanded to WBCs, can also be called leukocytes. And platelets are so incredibly necessary. They're involved in clotting. And these are cell fragments, and I'll show you some pictures shortly. Let's get some terms out of the way. Hemopoiesis The term poiesis, or the part of the word poiesis, indicates that you're making something. So hemopoiesis means you're making the formed elements, and we will discuss how that happens a bit later. Fractionation is a technique that is used by clinicians to very quickly and visually examine your blood. So you're breaking or separating the whole blood into the plasma and the formed element pieces. So looking at this picture, you see that this blood in this tube has been centrifuged, and when that happens, you can see that about 50%, 55% is plasma, and then you have this tiny little bit right here, which is about 4%, which is platelets, and then you have about 41% is red blood cells. But if you did this super quickly with a capillary tube, and y'all, that's the tiny, tiny, tiny glass tube that when your finger is pricked and the clinician puts the tube right up against your finger, the blood is drawn up into that tube. If you take a capillary tube and you spin it, you can just eyeball it. And if you have red blood cells that are significantly lower than, I'm going to say ballpark it, 50%, because when you're looking at those tubes, you're about 50-50. Say you could see it was only about 25% of the tube, that could indicate there's a significant issue, such as anemia. So blood is warmer than your normal body temperature. It's about 100 degrees, 0.4 Fahrenheit, 0.4 degrees Fahrenheit. It's viscous, so it's thick, and it is alkaline. The pH is in the 7.35, 7.45, just slightly alkaline. It is 7% of your body weight. Males have 5 to 6 liters. Females have 4 to 5 liters. And the difference is just based on muscle mass for males. Let's look at plasma. It's about 50 to 60% of your blood volume, but about 90% of it's water. So the majority of plasma is water. But if you break down that other 10% or so, you'll see that other solutes make up 1% and plasma proteins make up 7%. So the plasma proteins that we have are mostly albumins. This allows for you to have this osmotic pressure of plasma, and it allows for the transport of lipids, steroids, and steroid hormones. Albumin, if you have ever looked at the white of an egg, that is essentially albumin. We also have globulins. Again, they are there for the transport of hormones. Lipids, it has an immune function, and it also transports ions. Fibrinogen, so incredibly important in clotting, and it can be converted into fibrin, which is a fibrous material, right? It's a protein that is fibrous. And then we have these regulatory proteins that are less than 1%. When you look at the other solutes, which is 1%, it's crazy to think about this, but electrolytes are part of that 1%, and we know how incredibly important our electrolytes are. Sodium, potassium, calcium, magnesium, etc. We have organic nutrients that are necessary to make ATP. If you don't have ATP, you're not here. And it also has what's necessary to maintain cells. So it's maintaining the cells. We have lipids, we have carbohydrates, and amino acids, and then there's wastes in there. Urea, uric acid, creatinine, bilirubin, and ammonia ions. So the other solutes is a very small percentage, but is incredibly important. When we compare interstitial fluid and plasma, we know that they are going to exchange substances because we have the very, very smallest of our vessels, that are called capillaries. Their walls are only one cell layer thick, and then there is this constant exchange of water ions and small solutes. The differences are the levels of O2 and CO2. It depends on where we're at within the capillaries, but we know that there is going to be more O2 and CO2 in the plasma than there will be in the interstitial fluid. The dissolved proteins that are in our plasma actually don't pass through the capillary walls. So let's just pause for just a minute and think about this. When we learned about proteins in ANP1, one of the things I kept trying to impress on you is that proteins have great difficulty going through a cell wall. They're big, they're bulky, they just don't make their way through. If you've ever had a urinalysis and someone says, the clinician says, well, you have a lot of protein in your urine, that means you're out of homeostasis because you really should not have protein in your urine. All right, so the plasma proteins do not pass through the capillary walls, albumins, globulins, and fibrinogen. Looking more closely at these plasma proteins, you see albumin is 60%. So when you look at this image, you see all of this is albumin. And then we have our globulins, which are 35%. The globulins are either antibodies, which are also called immunoglobulins, or transport globulins, such as hormone binding proteins necessary to transport things such as thyroid hormones. We have transferrin. If you remember, transferrin is incredibly important for the transport of iron. And then we have apoproteins, like lipoproteins, which are going to be transported, and then steroid binding proteins. All right. Fibrinogen is the third of the major plasma proteins. The molecules form clots because you have this long insoluble strand of fibrin. If you have plasma that has had the fibrinogen removed, then it is called serum. The other 1%, incredibly important. We have the enzymes, the hormones, and the prohormones. All of these are necessary for TSH, FSH, LH, insulin, and prolactin to be supported. 90% of all plasma proteins are made in your liver. The antibodies from the globulins are made by lymphocytes, and then you have peptide hormones that are made by endocrine organs. With this image, you can see that we have albumin here, we have fibrinogen here, and then we have that 35%. This is immunoglobulins that makes up part of that 35%. This also makes up part of it here and here, right? And then you have this 1%, this small area right here. Now let's look at red blood cells, shorthanded to RBCs. They make up 99% of the blood's formed elements. So let's think back to that tube that you saw. Let me just draw it right here. Remember that tube you just saw? If I draw a line right here, and you have a substance here, and you have a substance here, it's been spun. This up here is plasma. This down here are your formed elements. Red blood cells make up 99.9% of your blood's formed elements. So you look at this and you think to yourself, this is all red blood cells. Mostly. It is mostly. They're small, they're specialized. If you notice their size is between 7.2 and 8.4, you could just say 8, that's fine. Micrometers in size, they're not very wide. They're between 2 and 3 micrometers at their widest point, and then 1/2 to 1.1 at their narrowest point. A healthy red blood cell looks like a day-old jelly donut where the center has sunk and you have your outside ridges are higher. So it is thin in the middle and thicker at the edge. It's necessary to have this high surface to volume ratio because you need to quickly absorb as much oxygen as you can grab on to each red blood cell and then release it as necessary. These discs are stackable. It allows them to go through blood vessels, and they can also bend and flex. Remember, we have some capillaries that are 4 micrometers in size, and so this 8 micrometer red blood cell can bend and flex as it goes through those tiny capillaries. So when you hear that you have to have a red blood cell count, your RBC count, or you get test results back and that's what they're looking at 1 microliter of whole blood, right? What I just mentioned to you about taking the tube and spinning it, it's actually called a hematocrit, which is the packed cell volume, a PCV. This is the amount of red blood cells in centrifuged whole blood. And notice that males are 40 to 54%, females are 37 to 47%. But again, if you're just eyeballing the tube, a good rule of thumb is about 50%, right? I mean, if you can eyeball 40%, that's good. But it's a really good way to measure and get a good visual that allows for you to see if there is a problem with a person's red blood cells. Why is there this huge difference for males and females? And that is due to the androgens that allow for the stimulation of red blood cell production, muscle mass. They're just bigger. And so they have more red blood cells and more blood as a whole. Red blood cells don't have nuclei, they don't have mitochondria. Excuse me, red blood cells don't have nuclei, not anuclei. They don't have mitochondria and they don't have ribosomes. So that tells you something very, very quickly. They don't make proteins. They don't go through mitotic cell division so that they can make more. And they don't make ATP. They live about 120 days. Red blood cells have hemoglobin. That is a protein molecule that allows for the attachment of O2 and CO2. So for normal hemoglobin, you have 14 to 18 grams per deciliter for males and 12 to 16 grams per deciliter for females. Looking at the structure of hemoglobin, you may remember this from A&P1 when we talked about making proteins. It is a protein that has a complex quaternary structure. So remember that each one of these is the tertiary structure. So the tertiary structures come together to form the quaternary structure. So these are 4 globular protein subunits. Each one has a molecule of heme, right? So there's 4 molecules of heme, and each one of these contains iron, right? Here is your iron ion. Oops, iron ion right there, right? And you can see it in the chemical structure right here. Iron is necessary because it associates with oxygen, or it can disassociate from oxygen, and that's called deoxyhemoglobin, right? So it can easily grab on and easily let go. So each one of the red blood cells has 280 million of these hemoglobin molecules, right? 280 million of these. So there's 4 heme units in each one. So if you multiply 280 million times 4, each red blood cell has more than 1 billion O2 molecules that attach. Before you're born, you have something that is called fetal hemoglobin. And it is a super strong form of hemoglobin because it essentially has to steal oxygen from mom at the placenta in order to gain, the fetus has to gain oxygen. So this fetal hemoglobin is going to be lost, and it continues over the first year. I see a misspelling. That's supposed to be lose, not loose. And a baby will lose about 5% of the fetal hemoglobin every month. What's cool about this is fetal hemoglobin can be stimulated in adults if they have sickle cell anemia or thalassemia, right? Only the adult form of hemoglobin is abnormal. So if you can stimulate new hemoglobin, fetal hemoglobin, which has a stronger affinity for oxygen, then the person may have lessened sickle cell anemia or thalassemia symptoms. So sickle cell anemia, a person who has that, their red blood cells, or the majority of their red blood cells, are not that very nice round shape. They are sickle shaped. So they are smaller, they have less affinity for oxygen. They also are sickle shaped, so they're pointy. They don't go through vessels very easily at all. A person with sickle cell anemia can experience lethargy, tiredness, or exhaustion. They can also have great pain in their appendages or different areas of their body. They can also have damage to vessels because of the damage that the sickled cells can do. Thalassemia is a type of anemia where there is less attraction of the hemoglobin to the available red blood cells. Sickle cell anemia is more traditionally found from people who are of African descent, and thalassemia is more often found in people who are of Mediterranean descent. Your body will produce something that's called carbaminohemoglobin when you're in a situation where you have low oxygen in your peripheral capillaries, not your deep capillaries, but your peripheral capillaries. When this happens, your hemoglobin releases oxygen and it makes your plasma CO2 high. Then your alpha and beta chains bind that carbon dioxide and it carries it to the lungs. So you're actually carrying this carbaminohemoglobin to the lungs. When that happens, you have this carbaminohemoglobin that's formed. Your red blood cells will then absorb the O2 and release the CO2, right? This can happen to a person when they're in an area of high elevation because your body's trying to keep as much oxygen as it can. So as we've talked about before, your body is incredibly efficient. And after 120 days, or if there's been damage to red blood cells, your body is going to recycle as many as possible. Let's just look at the image first. In your bone marrow, you make red blood cells. So we go from the stem cell to the making of the red blood cell. It's released into your circulation. You're going to lose about 10% of those. They're not formed correctly. For whatever reason, they go through hemolysis. Remember, lysis is to break. but the other 90% is going to live that 120 days. Once it's lived the 120 days, it's going to be ingested by a macrophage. When that happens, it's broken apart and amino acids are recycled and sent back to bone. The heme is recycled, the iron is pulled off, and the iron is transported by transferrin, and that goes back to the bone. And then we have the waste products, biliverdin and bilirubin, right? Now this macrophage is in your spleen, your liver, and your bone marrow. It's just not any random macrophage. Biliverdin is converted into bilirubin. Bilirubin enters your liver, and bilirubin can be removed from your body in two ways. One of the ways is straight into your urine. Bilirubin has a yellow color, by the way. Another way that bilirubin is removed from your body is it enters your small intestine, goes to your large intestine. It's broken down. And when it's broken down, part of the products, again, go to your kidney so it can be eliminated in urine. And then part is going to be broken down into urobilins and stercobilins, and that's eliminated in feces, right? So we have this hemolysis that occurred to 10%, and some of them, old damaged red blood cells, are going to go through that same process, and some is going to provide it's going to be removed from your body through your kidneys. All right, let's talk about a bruise for just a minute. This may be a little early, but let's talk about it. When you bruise yourself, let's say you run into the corner of a table and you know that you're going to get a bruise. When you first look at it, it's red. And then over a few days, it might turn black, blue. Then a few more days, it turns green. And then a few more days, it turns yellow. Well, the red is bleeding under your skin. The black is the breakdown of the cells around the damaged area. The green is biliverdin. What is verde in Latin? Green. The yellow is the production of bilirubin. So you have the breakdown of the red blood cells, and that's what causes the color. All right, so I think we've gone through all of this. You have macrophages in your liver, your spleen, and your bone marrow. They monitor all your red blood cells, and they break down the old ones or the damaged one. The phagocytes are going to break the hemoglobin into its components. You have globular proteins are going to be turned into amino acids. That's what you're seeing right here. Heme is going to be broken down into the iron that is recycled and into biliverdin and then bilirubin, etc. So we've recycled the iron. I talked about the biliverdin and the bilirubin. All right. The urobilins and the stercobilins are actually made because you have intestinal bacteria that break down that bilirubin, and stercobilins and urobilins allow for the color and the aroma of feces. If you are not in homeostasis, you may have hemoglobinuria. This is the breakdown of hemoglobin products in your urine because you had excess hemolysis in your bloodstream. Hematuria is when you have whole red blood cells in your urine. If you've ever had a urinary tract infection or a kidney infection, then you may have had blood in your urine, and that was whole blood cells. Anemia occurs when a person could have decreased red blood cells. There are many different ways to do this. Pernicious anemia is very specific. You're just not making enough red blood cells, and that's because a person is low on vitamin B12. As we talked about, red blood cells do not go through mitotic cell division. They have stem cells. And so when a red blood cell goes through maturation, it's called erythropoiesis. This is red blood cell formation. It occurs in your red bone marrow, which is called myeloid tissue. And the stem cells are going to mature to become red blood cells. EPO is a hormone that is necessary for this to happen. When a person is in an area that allows for them, such as a high mountainous area, when oxygen is low, or perhaps they have a health condition that allows for them to have low oxygen, EPO is going to be secreted. When EPO is secreted, that allows for erythropoiesis to be triggered. Hemocytoblasts are stem cells that are found in the bone marrow, and they are going to divide to either produce myeloid stem cells or lymphoid stem cells. Myeloid stem cells make red blood cells and some white blood cells, and lymphoid stem cells become lymphocytes. So with this image, you can see that here we have a proerythroblast. This is the initiator. And then you have the erythroblast going through the different stages. You're not going to have to know all this, but I would like for you to see that we actually kick out the nucleus. And you form something that's called a reticulocyte on day 5 through 7. And that reticulocyte is going to enter your circulation, and it's going to mature into a red blood cell. So you're looking at about 7 days to go from a proerythroblast, the precursor, all the way to a mature blood cell. If you're in a clinical situation, you may have red blood cell tests that are done. The hematocrit, again, that's just looking at formed elements. But remember, 99% of formed elements are red blood cells, so this is also a way to check the number of red blood cells. If you have an elevated count, you may have something called polycythemia. So instead of it being a 50-50 or a 40-60 split in that tube, let's say you have 70% red blood cells, you may have polycythemia. And I want you to think about what happens when someone has more solids in a liquid. What would happen with your blood pressure, right? It would elevate it because you're trying to push a thicker fluid through those vessels. So that's elevated red blood cells. If they're depressed, then a person could have anemia. If you're looking at reticulocytes, remember these are the precursor to the red blood cell. If it's elevated, you may have a disorder called reticulocytosis. Your hemoglobin concentration, if it's low, you may have anemia. Red blood cell count, again, you may have erythrocytosis or polycythemia. If it's depressed, anemia. Your mean corpuscular volume, that means the volume of a single red blood cell, right? The average volume of one red blood cell. You could have something called macrocytic or something called microcytic. The mean corpuscular hemoglobin concentrations may mean that you're either hypochromic or hypochromic. Either way, you are out of homeostasis. The ones I'd really like for you to concentrate on are the red blood cell counts and the hematocrits. Let's look at blood types. You know that your blood type is determined based on your parents' blood type, so it's genetically determined. And a blood type is essentially nothing but what's on your red blood cell, what's on the surface. What are the antigens? Do you have A antigens, B antigens, or RH, which is the same as D antigens? All right. So looking down at this picture, here's a red blood cell, and this one has surface antigen A. They're the round circles. This is type B. They have surface antigen B. See these structures poking out, and that's exactly what it looks like. Not circles and triangles, by the way, but you have these structures that are attached to the surface of your red blood cell. If you are A and B, you have both of them. If you're type O, you have none. All right. So these surface antigens allow for identification to occur so that your immune system can identify what type of surface antigen you have. And if you are exposed to a different type of cell that has a different type of antigen, then this is going to trigger an immune response. So if you have normal cells, cells that look like yours, then they're going to be ignored. But if there is a foreign cell that is found, it's going to be attacked. We shorthand antigen to AG, and just remember, antigens allow for recognition of self. So agglutinogens are another term for the antigens that are found on a red blood cell. Your immune system screens it, and you have antibodies that are in your plasma that will attack. So type A has type B antibodies, type B has type A antibodies, type O has both A and B antibodies, and type AB has neither A nor B. All right, so here is a blood sample. It has anti-A, and the blood type is A. So you can see that when it's exposed to anti-A, it agglutinates, all right? Remember, D is the same as RH, so you're either RH plus or RH minus. All of these blood types are plus because the first three blood types, because they're plus, that means that there's going to be an agglutination reaction because it does have the D antigen, and this is anti-D. All right. Again, this is the blood type B plus. It has the plus here, and because of that, it's going to have an agglutination reaction with D. If it's exposed to a blood sample that is anti-B, then you can see that it is going to have a agglutination reaction. But if it's exposed to anti-B, there's no problem. Right, all the way down you can see the same thing. But here we have O negative. So O negative, it does not have the D antigen, so there's no agglutination reaction here. It does not have any antigens on the outside, so it can be exposed to anti-B antibodies and anti-A antibodies, and there's going to be no reaction. So these reactions that we're looking at are cross reactions. When you have this agglutination reaction, this is agglutination, it's going to result in hemolysis, where you destroy the red blood cells. So the surface antigens here are pointy. These are the opposing antibodies. Notice they accept the point. When that happens, and they have antibodies attached to them, they all begin to agglutinate, and then hemolysis will occur. This is also called a transfusion reaction. This is the reason why it is if you have type A, type B, or type AB blood, to make sure that you get the blood type that is the same as yours, unless you get type O, because it doesn't have surface antigens. So O is known as the universal donor. AB is known as the universal recipient. So I mentioned this Rh factor that is also called the D antigen. You may be much more familiar with it being called the Rh factor. So every individual is either AB, or O plus or negative, right? So if a person who is Rh negative has been exposed to Rh positive blood, they're going to build up antibodies, right? So there may not be an issue the first time, but the second time they're exposed to that blood, they will have an antigen antibody response. All right, so this is where it becomes an issue. It's about women having babies. So if an Rh positive mom, she has the D antigen, has an Rh negative baby, that is not a problem. She has not been exposed to, she already has the Rh positive, right? So she has not been, there's nothing for her to be exposed to. She never will have any problems. But if there is an Rh negative mom and an Rh positive dad, and they have an Rh positive baby, that baby is fine. Okay? That baby is going to be fine. However, when that baby is delivered, there is going to be mixing of blood, and mom is going to make anti-Rh antibodies. So she's going to have rolling through her system these anti-Rh antibodies. If she has a second baby that is Rh positive, those anti-Rh antibodies are going to attack that baby. And that can cause death at or before delivery. This can be known as the hemolytic disease of the newborn, HDN, or it's known as erythroblastosis fetalis, EF. If a baby is born with this, it can be anemic and jaundiced because its red blood cells have been destroyed, and it may have to have a complete blood transfusion. So in order to stop this, a mom can get RhoGAM shots. That prevents the production of the anti-Rh antibodies for the last 3 months of pregnancy and before and after delivery. Right, here's just another way to look at it. Think about what your blood type is, and when you look at your blood type, you can see that you have these antigens sticking off your cell. If you do not have the Rh factor, you do not see the additional antigens. If you do have the Rh factor, so you are A positive, B positive, or AB positive, or O positive, you have the Rh factor attached also as an antigen, right? So here's a really good example of how hemolytic disease of the newborn occurs. It's everything that I just talked about, right? But I thought you might like to see it in a more visual form. Leukocytes, or white blood cells, don't have hemoglobin, but they do have nuclei and they do have other organelles. So it's clear from this that they have other functions that are completely different from red blood cells. So they defend against pathogens, remove toxins and waste, and attack abnormal cells. Most of the time, your white blood cells are actually found in your connective tissue proper and in your lymphatic system. There's very small numbers in the blood. That's the reason why when you do a hematocrit, you just have that very, very thin, maybe 4% in the hematocrit is going to be white blood cells. They hang out in your connective tissue in your lymphatic system, and they go in and out of your blood as needed. As I said, they migrate, and they do that through a process that's called margination. Those white blood cells that have received the chemical cue to become active are going to stick to your vessel walls, and then they squeeze through those endothelial cells between them. So it can be done either through emigration, which means to leave, or diapedesis. When they do this, they have this amoeboid movement, which is gliding, which needs calcium and ATP in order to work. This movement of emigration means that there is some chemical call. It's called chemotaxis, and when they're calling something to a place, that's positive chemotaxis. When something is being sent away from a place, that's negative chemotaxis. These chemical cues guide these white blood cells to whatever is needed to be taken care of, whether it's a pathogen, a bacteria, or a virus, or a fungus, whether it's damaged tissue, or maybe it's other white blood cells because the other white blood cells need help. Some white blood cells are phagocytic, which means they're going to eat other cells. Neutrophils, eosinophils, which sometimes are called macrophages, and then monocytes, which are the macrophages that we have consistently talked about. Their job is to engulf waste and the pathogens. Let's look more specifically at the different types of white blood cells. The first white blood cell we're going to look at is a neutrophil. Neutrophils uncommonly are called polymorphonuclear leukocytes. So let's look at the nucleus of that cell. You can see it in dark purple. You can see the large neutrophil surrounded by red blood cells. The nucleus of the neutrophil has many bodies, polymorph, that make up the nucleus. This is the majority of the circulating white blood cells, neutrophils. They're big, 12 micrometers in diameter. They live 10 hours, but before they die, they eat 12 to 24 bacteria, which is pretty amazing. What's even more amazing is that someone figured that out. They are, the nucleus has 2 to 5 segments. The one that you see here is 3 sections. They have granules that you can see within the cell itself that are lysosomal enzymes. So they are going to, these enzymes are going to lyse other cells, and bactericides. And bactericides have the job of just killing. They have a chemical on the inside that will kill bacteria. Whether it's hydrogen peroxide or a superoxide, it's a bactericide. They're the first ones on the scene. They're the first ones to attack bacteria, fungi, some viruses. They engulf whatever the invader is, they digest it, and then they release hormones, either prostaglandins and or leukotrienes, and that calls, both of those call other cells to the site, right? They make up inflammation. They're part of the reason that we have inflammation. Because of this release of prostaglandins and leukotrienes, and they are the reason why we have pus in our areas where we've had an infection. Eosinophils are also called acetophils. So this staining on here, as you can see, is for acids. They are also 12 micrometers in diameter. 2 to 4 of the circulating white blood cells, 2 to 4% of the circulating white blood cells, so it's a very small number, are eosinophils. They have a 2-lobe nucleus, as you can clearly see, and their job is to attack large parasites, but they're also sensitive to allergens. So if you go and you have a complete blood test done, a CBC, and they say you have high eosinophils, the clinician is not going to be able to determine whether or not it's due to parasites or due to an allergic attack. So the question might next come to you is, have you been out of the country recently, right? So their job is to control inflammation. Now remember, neutrophils actually encourage inflammation. Eosinophils control inflammation, and they counteract that inflammatory effect of the neutrophils. Basophils are a very small percentage of all circulating white blood cells. They're only 1%, and they're small, 8 to 10 micrometers. They are going to go to the site where they're needed via capillaries, and they gather in this damaged tissue and release chemicals that are going to attract more basophils and eosinophils. So that's positive chemotaxis. The granules that they have on the inside contain histamine and heparin, and that's going to dilate blood vessels and prevent blood clotting, and both of those enhance inflammation. So now we have two, neutrophils and basophils, that enhance inflammation, but basophils are also going to call in eosinophils, and that's going to decrease inflammation. Monocytes are huge in comparison to the rest of the white blood cells. They're a small number, 2 to 8% of the white blood cells. They're large, they're spherical, they have a large kidney-shaped nucleus. They enter the tissues and become macrophages after 24 hours, and that's when they become aggressive. You know, a macrophage has the ability to eat. They're big eaters, and then they also secrete substances that attract other immune system cells, again, positive chemotaxis, and it also attracts fibroblasts to the injured area that will help with repair. Lymphocytes are 20 to 30% of all white blood cells. They are small, but they're larger than red blood cells. As you can see in this picture, not only can you see all the red blood cells, but you can see their size in comparison to lymphocytes. And also in this picture, you can finally see a platelet. So you have all three of the formed elements in here. They migrate into and out of the blood. They hang out mostly in the connective tissue and lymphatic organs. And lymphocytes are part of the specific defense system for your body. We'll talk much more about that when we get to immunology. There are 3 classes of lymphocytes: T cells, B cells, and natural killer cells. Again, more information on those when we get to immunology. T cells mean that we have cell-mediated immunity. This is a direct attack on foreign cells. Also, there's coordination of the entire immune response. B cells means humoral. So the word humoral comes from the word humors, and the fluids in our body used to be called humors. And humoral in this sense means that they run through the entire body. So the job of B cells is to not just produce, but also to distribute antibodies. The B cells will differentiate into plasma cells. Again, that's making and distributing the antibodies. Natural killer cells is the 3rd type of lymphocyte, and their job is immune surveillance. And with this immune surveillance, it is the constant watching, being security, and their job is to detect and destroy abnormal tissue cells such as cancer. If you're out of homeostasis in regard to your white blood cells, you could have something called leukopenia, which means you have abnormally low white blood cells, a number of white blood cells. You could have leukocytosis. That means you have many abnormally high white blood cells. Leukemia means that there is an extremely high white blood cell count. So if you look at the image below on the left, you can see the normal. If you're looking through a scope, you'd see the normal distribution of white blood cells and red blood cells and platelets, but you can see what happens with leukemia, that there is an abnormally high number of white blood cells. Lymphoma is a type of blood cancer that occurs in the lymphatic system, and this is when you have white blood cells that change and grow out of control. Again, on the right, you can see that there are normal cells, and then you could see that there are cells that have grown out of control. So a person can have Hodgkin's lymphoma or non-Hodgkin's lymphoma. These are the two major types, and the image is of Hodgkin's lymphoma. In order to make white blood cells, we have to go through either myeloid stem cell production or lymphoid stem cell production. All blood cells, does not matter what type it is, whether it is a platelet, a red blood cell, or a white blood cell, are going to originate from the stem cell that is the primary stem cell, which is a hemocytoblast. The hemocytoblast is then going to either produce myeloid stem cells. Well, it produces both myeloid stem cells and lymphoid stem cells. And you can see that in this image. The hemocytoblast is the very top image, and you can see the two arrows coming off of it where you can see the production of either myeloid stem cells or lymphoid stem cells. Let's just follow that myeloid stem cell line. As we follow the myeloid stem cell line, you can see the hormone EPO comes into play. It interacts with the progenitor cells, which interacts with the blast cell. Remember that blast cells are immature cells. Again, EPO comes into play. Then there's erythroblasts, then there's reticulocyte. Essentially, we're going to get to a red blood cell, right? But it takes EPO and stem cells to do this. And they all started from this myeloid stem cell. Remember, this is in the bone. All right, in order to get a platelet, we again go from the myeloid stem cells to the progenitor cells. We get to what's called a megakaryocyte, and the megakaryocyte is going to split up and you're going to get platelets. All right. This myeloid stem cell is also going to give rise to, and please don't think that you have to know all of the bits in between, you do not, but the myeloid stem cell is going to make the progenitor cells, just like you see here, but it depends on what interacts with it, right? Because these progenitor cells are exactly the same. But if you have the compound GCSF, then you're going to produce myeloblasts, and then those myeloblasts can go through the process where they're either going to become a basophil, eosinophil, or a neutrophil. If that the blast cells are hit with MCSF, then the product is going to be a monocyte, and you know that monocytes become macrophages. All right, but like I said, lymphocytes, T cells, B cells, and natural killer cells are the only ones that go through the lymphoid stem cell process. And again, you have a lymphoid stem cell that becomes an immature cell, a blast cell. Then it goes through the process and it becomes a lymphocyte, right? So we have lymphopoiesis that allows for the making of lymphocytes. Erythropoiesis allows for the making of red blood cells. As we've said, everything except white blood cells, except monocytes and lymphocytes, develop in the bone marrow. Monocytes are going to develop in peripheral tissue. They're just really different. So you have basophils, eosinophils, neutrophils that are going to develop fully in the bone marrow, right, in regard to white blood cells. When the lymphoid cells are mature, they make their way, or when the lymphoid stem cells get the cue that it is time to make more lymphocytes, they're going to migrate into lymphoid tissue that you find in your thymus, your spleen, and your lymph nodes, and they produce lymphocytes there. Platelets are the third type of formed element, and these are cell fragments. Remember that huge megakaryocyte that I just showed you? Well, they're going to break apart and become platelets. They're small, 4 micrometers in diameter. And remember, your frame of reference is a red blood cell that is 8 micrometers in diameter. Remember, you have some white blood cells to get up to be 12 micrometers in diameter. So platelets are small. They only circulate for 9 to 12 days, and they're removed in your spleen by phagocytosis. 2/3 of your platelets are just hanging out and are reserved for emergencies. Their job is to release clotting chemicals and patch vessel walls and contract tissue after clot formation. So here's a great image where you see platelets and red blood cells and lymphocytes and neutrophils, basophils, monocytes, and eosinophils all in your blood at this point. All right, great image so that you can see the relative size and amount within your blood. So if you have a platelet disorder, you could have something called thrombocytopenia. That's a low platelet count, which could lead to hemorrhaging. Thrombocytosis means a high platelet count that could lead to excessive clotting, which means you could throw a clot and perhaps have graver clinical issues such as a stroke. So in order to make platelets, it's called thrombocytopoiesis. So you have lymphopoiesis, erythropoiesis, and thrombocytopoiesis. This occurs in the bone marrow, as I previously said, and this is how platelets are made in the cytoplasm from megakaryocytes. So here is the image of the megakaryocyte. Right, here's a great table that is a summary of the formed elements of blood. You have the relative sizes, the relative amounts, and what they do. So what happens when you do start bleeding, right? Well, hopefully you will stop bleeding, and the process of stopping bleeding is called hemostasis. Right? So stasis means to pause or stop. So there are 3 phases for hemostasis: the vascular, the platelet, and the coagulation phase. So if you look at the image, you see that there has been a vessel that has been cut, right? And so not only are we trying to work with what is going on within the blood vessel, but we also have to think about what's going on with the vessel itself, because we have to repair that vessel. So the first step is the vascular phase. This is where you've had damage, a cut to a vessel. A 30-minute contraction will occur, and that contraction will slow the flow of blood. It occurs in 3 mini phases, this vascular phase. The endothelial cells, which are the cells that make up the vessel, are going to contract. The second thing that they're going to do is they're going to release chemicals that are going to be chemical calls, and they're going to release local hormones. And both of these are going to stimulate muscle contraction, because remember, in your vessels you have smooth muscle, and they're also going to stimulate cell division. The third part of this mini phase is that those cells become sticky. And when that happens, they seal off blood flow. So I don't know if you've ever heard that if you cut yourself and it hasn't stopped bleeding within 30 minutes, you actually might need to have stitches. So if you've put ice on it and you're holding it upright, letting gravity help you, and it still hasn't stopped, it's because whatever you cut, or how deep you cut it, or the multiple vessels that have been cut, are not able to slow down this bleeding in this first step in hemostasis. The second step occurs within 15 seconds after injury, and this is called the platelet phase. So the platelets that we just talked about, those cell fragments, are going to stick to those sticky endothelial surfaces. So this is called platelet adhesion, and they're going to stick, and they're going to continue to stick until they aggregate. So that is platelet aggregation, and a platelet plug is formed. And you can see in this image, here is the platelet plug. So this is the cut edge of the vessel wall, right? And this platelet plug has formed to try to seal it off. So this is inside the vessel here, outside the vessel here. When you have this aggregation, you have these platelets that have been activated, and they release clotting compounds, which include adenosine diphosphate, something called thromboxane, and serotonin, different clotting factors, platelet-derived growth factor, and calcium. And all of these come together to end this, what is called platelet phase. Once you have this platelet plug formed, then you have prostacyclin that's going to be released. That's going to inhibit platelet aggregation. Other cells, white blood cells, are going to produce an inhibitory compound, again, to keep the platelet size down, platelet plug size down. There are enzymes that are circulating in the blood. They break down the ADP, which helped, ADP, remember, helped to build up the plug. When serotonin is there, there is negative feedback. So that is going to also inhibit the plug size. And then blood will clot, which isolates the area. And that also allows for the size restriction of that platelet plug. The third phase is the clotting phase, or coagulation phase. So this should begin 30 seconds or more after the injury. So you can see that you have damaged tissue. Your smooth muscle cells are still contracting so that the vessel opening is constricted on both sides. There is the platelet plug that you can see. Here is the platelet plug. And then your blood is actually going to start acting to stop this situation so that your bleeding will slow down or cease. So within your blood, you know one of the things that you have is fibrinogen. Remember, we talked about albumin, we talked about globulins, and we talked about fibrinogen. Fibrinogen is going to be converted into fibrin. So if you look at the bottom of the blue arrow, you see fibrin. But the process of converting fibrinogen into fibrin takes a few steps. When it's completed, that blood clot, which is the fibrin network, is going to cover that platelet plug. It's going to trap the blood cells and it seals off the area, right? So not only do you have a platelet plug, but you have a blood clot. But in order for this clot to be formed, you must have some clotting factors. So within your plasma, you need to have proteins or ions, and these are all required for normal clotting. This is a reaction that is truly a cascade reaction, because once one thing happens, then it's going to trigger something else, and it's going to trigger something else. And we are looking at the chain reactions of 3 different pathways. All right, so the 3 coagulation pathways include, first, the extrinsic pathway. So this side is the extrinsic pathway. It's going to begin in the vessel wall outside the bloodstream, and tissue factor is going to be released. Then you have other factors, right, that are then going to activate factor 10, right? This activation of factor 10, we're going to pause here for just a minute so that you can see that we also have an intrinsic pathway. So this intrinsic pathway, over here on this side, it's explained, begins with the circulating proenzymes, right? This is normally factor 12. And it allows for, well, it's activated because of collagen. And we have, again, this series of events. As you can tell here, I'm not super excited about you knowing all of these series of events are again going to allow for the activation of factor X. So you have the outside pathway, extrinsic, allows for factor X to be activated. Then you have the intrinsic pathway that allows for, factor 10 to be activated. When the intrinsic and the extrinsic pathways come together in your bloodstream, then we have what's called the common pathway. We've got to have vitamin K that is available. We have factor 10. This common pathway is going to allow for prothrombinase to be, and prothrombinase is going to allow prothrombin to be converted into thrombin, which allows fibrinogen to be converted into fibrin. Don't get too wrapped up in this. You need to know that there are multiple steps in order for fibrinogen to be converted into fibrin. I would like for you to know that there's an extrinsic pathway that is outside. There is an intrinsic pathway that is inside. They come together and form a common pathway. All right. And here is a great overview of everything that I just said about hemostasis. So once the clot has formed, the platelets are actually going to contract and pull the torn areas together with the hope of fixing the vessel itself. Over time, fibrinolysis is going to have to occur, and this is the process of dissolving the clot itself. It's going to take plasminogen that produces plasmin that is going to digest the fiber strands. In order for clotting to occur, you have to have calcium and vitamin K. As you can see here in the image, vitamin K helps you to clot, and it helps you to form these blood clotting proteins that are necessary. And that's going to hold the blood cells together. If a person doesn't have enough vitamin K, maybe the person is taking a very old but still widely used drug such as warfarin. It reduces the body's ability to interfere, to make vitamin K, which is going to interfere with protein creation. This will lower your level of clotting. So warfarin, sometimes called Coumadin, is an anticoagulant. It is still commonly used as a rodent poison. So if the rodent ingests this, they essentially bleed out. If a person is taking warfarin or Coumadin as a blood thinning agent, if they have high blood pressure, then they must be very careful about the dark leafy greens that they ingest, because the dark leafy greens have a lot of vitamin K in them. A person who is on warfarin or Coumadin must have their blood checked quite often, either every 2 weeks or once a month. And so if they eat dark leafy greens when they have their blood checked, it may give a false reading about the amount of vitamin K that they have.